Welcome to the Medic Materials Podcast. If you're here for buttoned-up EMS professionalism and HR-approved opinions, you're in the wrong damn place. We talk real EMS, talk about some fucked-up calls, bad decisions, some system bullshit, and the stuff you only admit in the truck at 3 a.m. We will absolutely try to sell you some merch. Thank you very much. Accidentally teach you something. Maybe occasionally say something smart in between the sarcasm. So kick the kids out, let's turn it up, and prepare to be mildly offended. Let's get into it. Yeah.
Another thing.
Hello and welcome, everyone.
Oh.
What are you guys talking about while you're on mute?
Bullshit.
Bullshit. I heard something about bullets.
Screensaver, bullets.
Screensaver, bullets.
Flight simulators.
Okay. All right. Well, I have a message for you guys and everybody else out in Listenerville. Let's see if it works here. But I found a cool soundbite that might bring certain team members back to their utes.
The Utes.
Yep, your utes. Let's see if it'll actually play.
That's from a movie I'm on.
I believe you.
Playing, we still have the same problem and we can't hear it.
Yes, awesome. It was the theme song to Welcome Back, Cotter.
Oh, yeah, didn't hear it.
Yep. Sorry. You're
Yeah.
welcome. You're welcome.
Welcome back.
Yep, that's exactly what you heard. That's exactly what you heard. So,
Exactly what we
at
didn't
least
hear.
the audience heard. You didn't hear.
That was the original Epstein. It's who I keep thinking. It's who I always think about when I hear that name.
And he starts already, ladies and gentlemen. He starts already. Absolutely fantastic. I love
Cheers.
it. Yeah, cheers. Oh man, absolutely fantastic. So yeah, it's been a little bit. And I'm hopeful that the new way that we're gonna look at scheduling this will allow us to be able to actually record on a regular basis. So I'm pretty happy. Everybody else in Listenerville should be pretty happy. I think, when we used to sit there and go, okay, well, we need all 5 of us together in one room, or all 6 of us, however many there were at one point, because we're missing the Phil Foundation today.
It was a gaggle.
Yep, it was a gaggle. It was hard to get the gaggle in the same room all at the same point in time. And that's really the only reason why we have not been recording over the past few months. But I figured, Gerard, you and I spoke about it, and you and I being the OGs of the show, I feel uncomfortable doing the show without you. And I know the listeners don't ever want to hear the show without you. Like, I still to this day show the metrics. When you took your little sabbatical years ago, our listenership went
Okay.
and then you miraculously made a comeback, and then it was like, woo, took off again. So the popularity of the show is just you. People just pay to see you. It's really
I don't know, man. I don't know why.
I don't know why either.
It's that charming personality.
I was at a CME the other night with a group of people that are faithful listeners of the show, and shout out to them. They know who they are. And we were talking about, the show and how it's coming back. And they were like, when can we hear Gerard? I was like, well, thanks a lot. What about me and M and Butch and all the other ones? And they're like, nah, we just want to hear Gerard. I'm like, okay, cool, bro. Eventually, Gerard, you're just going to replace us and you can do the show without us.
He's the one who's going to go have a solo career. He's going to leave the band and go have a solo career.
100%. 100%. His voiceover career has already started. Let's put it that way. So yes, so more or less we are going to pick a day to record, and then whoever can make that day, that's who's going to be on the show. So you'll always get me because I have to record the damn thing. But then the revolving door of faces might be a little different each time, and I think that gives the variety and spice to the show. I have saved a call that we got in our inbox. My God, it probably was 9, 10 months ago that I've been sitting on this call because it's been that long since we recorded anything. I think we've done one show in the last year. So
I have to wash it.
You know, again, sorry. But I think it'll be an interesting one. And the conversations that we can have around this, I think will be really cool. So there's to looking forward. Just so everybody knows, if you have not gotten the memo, the Patreon page was shut down. I want to thank all the fans who signed up and became Patreons and gave us money every month for extra CME podcasts and stuff like that. But going forward, all of those shows are on the Medic Materials CME Academy, or they will be. I'm moving them over, as we move forward. So don't be going and looking for the Patreon anymore because it doesn't exist. Let's put it that way. Let's see. We got some introductions. I got to first introduce Mr. Maha.
We won't hear that either.
No? You can't hear that one either? Well, it's playing. There you go. Now you know which where it is in life.
We got to hunt that down. What the hell why can't we hear it? We've got to figure this out. It's only been 2 years, 3 years.
But I'll tell you, I don't honestly know why we can't hear it because
we used to hear it one time and then all of a sudden it just fucking went away.
I honestly think it has something to do with the fact that we record through the interwebs and all of the sound goes through the soundboard. But the interwebs goes also through the soundboard. So
right.
You should be able to hear everything on my end.
Right.
Like if you, I don't know. One thing that will always plague me is technology. We'll just say that outright because it will always be the bane of my existence. Let's put it that way.
We need a nerd.
Maybe there was a resource.
I mean, Kelsey found a nerd. We can find our own nerd.
I know there is a resource out there. We should
yeah, that whole interwebs thing really gets
only you could just type it in there and use this some kind of artificial intelligence to figure out the answer.
Fucking Grok thing.
There's
really.
What's that called again?
It sucks. It sucks that I don't use that nearly well enough. Miss Certified Badass. It's been a while. How we doing, Em?
Good. How are you?
I am peachy. We have missed you. I think you were on the last one. I honestly don't even remember. It's been so long. But the cool thing about if people are watching the show right now on YouTube or Facebook, if I end up putting it up on Facebook, we have a new face, a brandy dandy new face, never before seen on the podcast. Doesn't even have a theme song.
It's okay.
It's okay. You'll eventually get a theme song. So one of the cool things, as you guys will remember the history of the show, we brought in Kelsey as the EMT intern, and then she morphed into the paramedic intern Kelsey, and then she became a full-fledged paramedic and host of the show during that point in time. And one of the cool things that she and I had a many back and forth conversations in not only bringing a different perspective to the show, but also being able to learn and ask questions that we weren't thinking of because we weren't a student anymore. And I thought that was a great resource to have on the show for listeners, and it made us think. I think it made the show ultimately better having her here. So one of the cool things is Megan's been with my EMT class now for quite a while, helping doing labs and scenarios and teaching and all this other stuff. And she's been a valuable resource with that. New York State EMT and now paramedic intern Megan.
Ooh.
I'm an intern yet.
You are. You are. You just don't know it yet. You might say that, but you are.
Can I just tell you, just saying that makes my heart rate go up. So,
well, you're welcome.
Yeah.
Eventually they're gonna release you to the wild and you'll kill a couple people, then you'll be fine.
And
Yeah.
it'll be just fine. It'll be just
Yeah.
fine. We're all friends here. No one judges except she judges hard.
You know you've made it when after you do that, you go, hey, anybody else hungry?
That was a big drama. Anybody for lasagna?
Right.
jeez.
So I think having you, Megan, being a part of the show as a student and as a provider, for quite a while, and bringing some of your hospital experience too in, will be a really cool addition to the future of the show. So welcome everybody.
Thank you.
Welcome Megan. Put it in the comments. Yay, Megan's here.
Hey.
Yay.
Sure.
I didn't actually put like a soundboard. Oh, here we go. We'll do this one. Yeah. And
I'll take
I should have worn my shirt. Damn, I'll tell you.
I could have worn mine too.
You could have. Yeah, we could have been shirt brothers.
I didn't think about it.
Nah, me neither. It happens. It happens. So I am gonna forego the rig check today because it's been a while and I've been yapping long enough. So we will continue that in the next.
Because the crew before us said everything was okay.
That's right, it's
all where it
fine.
should
You
be,
know
right?
what happens when you don't
Absolutely.
check your rig.
That's right. That's right.
Oh, we didn't do anything. It's fine. Okay.
It's fine. And then everything is missing. The seals are missing.
Hey, we don't have any drop
There's not even
sets.
any place for seals. Like, gotta love it. So are
where
you
do the
guys
narcs go?
ready to hear today's call?
Ready.
Drum roll. Da-da-da-da-da. All right. So here we go. Off and running for 2025. Your system
It's a
is a
firefighter's fault.
countywide
There you go,
ambulance with a little bit of an interesting twist. All right. This county staffs their ambulances with one paid EMT basic. And they also have fly cars that have a single paid paramagician. The ambulances are strategically placed at firehouses around the county. Now, the fly
This sounds familiar.
it does, right?
It does.
Right?
It does vaguely sound familiar. And the fly cars have their own stations. The ambulance then waits to respond if they get a call for one of the fire station members to come and form a full crew with the paid EMT.
Oh wow, okay.
It's
That's a
a
little different.
it's a paid EMT and a volunteer, either driver, CFR, or EMT that will drive and form that second person in the full crew. And then the paramedic goes on their own. So it's a little bit different. I've heard of these types of systems, but they are a little bit odd. So your hospitals, 2 hospitals within your immediate area, 1 community hospital that's designated only as a primary stroke facility. And that hospital is approximately 1 hour away. There's also a large medical center that is both PCI, comprehensive stroke, and level 1 trauma. That one is about 90 minutes away. Yep. So super far. Nothing is close. Not even a Band-Aid station that you could be like, oh, hey, this is helpful. Nope, nothing's close. So you guys are dispatched. Priority 1, a Delta priority to an intersection for a motor vehicle accident, classified as car versus motorcycle. Both the ambulance and fly car are dispatched to the scene, as well as the primary volunteer fire department, which also has EMTs and CFR first responders. While you guys are en route, you are updated. County informs the responding units a few minutes later that police have arrived on the scene, and it appears that the rider is not moving. So my first
They-
question.
They're gonna give Narcan, aren't they?
Oh, 100%. I mean, if they don't, all the Narcan sticker just is useless.
Right.
Which I will
This
say.
one?
Yeah, that one.
Oh, look at that.
There we go.
Little plug.
Or I should say, Mr. Krabs gets the ka-ching going. So when you guys hear motorcyclist not moving on scene, what is the mental checklist on that? Like,
are all his
haven't even
parts together?
arrived
Number
yet.
one.
Pulse breathing.
Yeah.
Pulse breathing. Does he have all his parts attached? I agree with that one. What else?
How many riders?
How many riders? That you don't like. I always think motorcyclist is one, but yeah, you could have two riders. Absolutely.
Was he dressed? Was
the
he
way
dressed
people-
for the slide, or was he dressed for the ride? You know,
Right. Right. Exactly. Well, no. One of the things I was, a great educator once told us during one of his classes, unless when you show up, if you don't see, like a custom chopper with one seat, assume two riders until proven otherwise, because people will fly when they get hit. So.
Oh yeah, absolutely. I tell this story in all of my EMT classes. I lost one of my good friends in high school to a crotch rocket accident. He decided to drive really fast where he shouldn't have been, plowed into a vehicle, and flew almost 200 feet down the roadway. Again, objects stay in motion. That whole law of physics still applies. We don't really think about the two rider aspect until proven otherwise. I really like that. I really, really do. So if we're kind of thinking, pulse breathing, does he have his parts? What kind of gear is he wearing? Is there two riders? All of this different kind of stuff. How do we then approach like the transport decision of this when everything is so far away? Is this like immediate, like call for the chopper, or like, what are we thinking?
Yeah, absolutely. I mean, if
Yeah.
I think, and ultimately these guys will, I will say that they ultimately will call the helicopter. The problem is they call the helicopter really, really late. Like this is one of those types of things where I hear this and it should be on dispatch, like.
I always ask, like, what do you think you're like you have to pay for the fuel or something? Like, why don't you just fucking call?
Or, I love, and I know we brought this up before, but I love the people who hear it and like haven't even gotten in their rig yet. And they're like, yeah, you can stand down the helicopter.
And then
like,
later call them back. My favorite.
Right. Then they call right back. Right.
Exactly. How many times has that happened to you now, M, flying?
Too much. Just let us keep going. It's okay. We're happy to get in the air. Don't worry. You can cancel us later.
Right.
They get to fly.
Exactly.
That's what they want
to do the cool part.
I don't want to just pull the tractor out. Let me get up.
Right.
I have situations now where some of the areas I respond into are, 45 minutes, an hour away from our nearest, level 1, PCI, comprehensive stroke, and you get called in for, possible stroke, possible heart attack. And they're like, oh, we'll just go with their, with their EMT level ambulance, and I'm going in as a fly card. I'll be like, I got a 45-minute hour ETA before I even get to you guys. Even if you leave the scene, we're still not meeting up for quite a bit. So maybe we want to start thinking about activating the chopper a little bit early here because
Yeah, and one of the things that I'll say, I know my wife has talked about a lot lately, is utilizing the helicopter as first on scene ALS, because ALS is coming from forever far away.
I'm just gonna say that sometimes your closest ALS is the helicopter, and that's totally okay. Totally fine.
And that's exactly what she says. Like, it's totally okay to, park at their door and be like, hey, you're my closest ALS, or have them come to the scene and be like, hey, you're it. Sorry. My paramedics coming.
I don't remember ever just running up to their window going, "Yeah, let me in."
I mean,
open the
you
door.
might not have, but there's a few that you could think of at my wife's base that might have been like, help me.
I've done it before.
I mean,
Go right to the base.
we've driven to it. And then we sat there.
Exactly. So the BLS ambulance arrives first on scene. They do grab their first in bag. Cool. Survey the scene.
What a plus.
I mean, they're already winning. They're winners in my book.
Yeah.
They see.
Maybe they want to see the wine list next, you know?
Maybe a little cheese on the side.
Right. Yeah.
They see the motorcycle in a ditch. Heavy front end damage. You could say that the front end is almost non-existent to the motorcycle.
I mean, somebody
That's bad.
was doing this.
Damage into the gas tank. So that tells you how far into the bike the damage
good.
goes. The rider is laying in front of the 4-door sedan on the pavement. As the crew walks up to the rider, they see a female kneeling by the person's head, holding head stabilization, and a trail of blood coming from what seems to be around the right leg. So as they continue to walk up, they're given a report by the female kneeling by the head. Now,
Please don't be a nurse. Don't be a nurse.
This is not the police officer. All right. This is a plainclothes human being.
That's a fucking nurse.
Yep.
Fuck.
You can't even say it.
Okay.
The 3 words you never want to hear on a scene. I'm a nurse.
I'm a nurse.
Or I'm a doctor.
Megan, one of the things that you don't understand about this show until you're on it and recording is how many times these guys all are like, this is what's going to happen. And then literally the next sentence is exactly what they just stated. So my next sentence was, she tells EMS that she's a nurse. And she was passing by the scene.
Of course.
So she decided.
That's when he asked, did you get permission from the doc to do this?
Oh.
No?
So
Is he your orders?
She stops and she did a rapid assessment and found that the male was laying on his right side under the front bumper.
Oh, damn, he fucked up.
Right? So, male laying on the right side under the front bumper of the vehicle. Cop butts in and says, according to his ID, he's 18, almost 19 years old. Helmet was still on. He's unresponsive but breathing. And the RN ended with, quote, she didn't find anything major, end quote. So I would like to raise the red flag here. I'll throw my red flag in the air. Does anyone
all the blood coming from that extremity?
No big deal though. There's nothing major.
Does anyone else find nothing?
Try the Narcan. Right.
Like unresponsive, bleeding, not serious. How do we respond to that statement on scene?
Mechanism of injury at the oh fuck level.
Thank you for your assistance.
Great job, and move on.
Go.
Yes.
Thank you.
Thank you for your service. Yes. What is it?
Thank you. Come again.
Thank you. Come again.
I have a question.
Oh my God, Kelsey.
Well, yeah, exactly. You just need to put a so in front of there and boom, Kelsey flashbacks.
So I have a question.
Sorry.
But you have to pause. It's so. I have a question.
No, I have to be my own person. I'm not Kelsey.
Okay, carry on.
Is the rider still underneath the front bumper or did she pull him out?
So when EMS got there, she had rolled him away from the front bumper. He's now laying supine in front of the front bumper.
Okay.
Still breathing after she moved him.
Still breathing, still helmet on.
I'm surprised.
Yes, agreed.
Log rolled and held stabilization at the same time.
Right.
That's some fucking feat.
That's pretty
there.
good. Yeah.
I mean,
she got like 4 hands or what?
Magic.
That's nurse level shit. We can't do that.
That's the big bucks.
She got an order for that,
Right.
you know.
So the the paid EMT takes the lead, begins the initial assessment. Okay, they become the primary. With the assistance of their partner, they remove his helmet, but maintain C-spine. They find that through removing the helmet, that this guy is responsive to painful stimuli with groans only, no words, just sounds. There's no abnormalities with the airway. There's no blood. There's no loose teeth. There's no debris. There's no vomit.
Thank you, helmet.
Yep. Chest is exposed. Lung sounds are clear on the right side, diminished but present on the left. Tender on palpation to the left chest wall, but feels intact. There's no bruising or outward trauma that they note. Peripheral pulses are present in all 4 extremities. Skin is warm, but I like this one.
How do they know?
Turning clammy.
How do they know it's tender? Did he go ow when he touched it?
Right.
Like,
I was gonna ask that.
I'm just telling you
saying
exactly
painful
what I
stimuli.
was-
So
That's where they got the painful stimuli from.
Maybe.
right. So if I'm
Okay.
palpating and someone goes, okay, probably painful.
Yep. I would agree.
What do I know?
So
But the diminished lung sounds and just writing it off and saying, oh well, it doesn't seem to be anything wrong. I was like, yeah, I don't know
give
about
it
that.
about 5 minutes, and then we'll see what really
Right.
happened.
Give it a think.
Yeah,
You know?
I agree. Just because it doesn't outwardly show trauma doesn't mean that inward there's nothing going on. Absolutely. So my favorite line of this whole primary, skin is warm, but turning clammy. He is not yet pale. I was like, okay.
Are we waiting for it or?
They describe it further when I did my debrief with this crew as an almost like in between pink and pale color. So, light pink. Who knows?
I wish I was that good at
Get
skin.
the 64 Crayola and have them mix it until you get the right shade.
Absolutely.
All right.
Like I would have just been like, yeah, they're turning shocky. Duh. Like,
Right.
What else do you want?
Don't look good.
The leg where the bleeding seems to be coming from is exposed. That would be the right leg. They find an open tib-fib fracture to the right leg, but no active bleeding is seen. So
Where's the blood coming from?
I'm going to ask, what is each of your guys' initial impressions of this patient?
Oh, there's something fucking wrong.
So he was bleeding. Now he's not bleeding from
Right.
the leg.
And
That's
that's
bad.
not good.
That's bad.
That's bad.
Agreed.
Yeah.
And
Are pulses equal in the feet?
well, so here's the thing that I think is interesting, right? It says peripheral pulses are present in all extremities. Is it really? Because
I was just about to say, and the lie detector said that was a lie.
Right? Either they have like completely exsanguinated this guy, and that's the reason why he's not bleeding, or there's no pulse down at the tib-fib to actively have bleeding. Like, what is going on here? So that's an interesting take on it. What else you guys got?
If we were to assume that, let's just say for shits and giggles that the bleeding didn't come from the open fracture, which it most likely did, then that means it's coming from somewhere else, and we should probably be really moving quickly to find it.
Yeah.
Yeah,
Right?
it's like
This-
expose
especially like-
everything right now.
Especially at the BLS level. Like,
Yeah.
we have to do
Scissors should be your
something quickly.
priority.
Yes.
Yeah, once you realize that the airway is good and the breathing's okay, let's get on with that C part where we're going to find all the bad C.
Yes.
We're going to cut things open.
I 100% agree. Em, what are you thinking here?
No, I mean, I agree. I think keep moving. Like, you're 90 minutes from where this patient needs to go. So like, don't stop. Keep moving.
And remember, they have not called for
Right.
any help at this
Which,
point.
I mean, I probably would have done that when I found that he's only responsive to pain. But
Agreed.
if you're not going to do that, keep moving.
But I also think you have to move with a purpose right now. Just don't move to do something. You have to move with the
Right.
purpose of trying to actually, keep this person from decompensating any further. You have to actually
Yeah.
And don't get
purposeful
caught up on the
things.
distracting injuries. Like, yes,
Yeah.
he has.
Yeah, I was
you
gonna
know,
say.
that
Yeah,
left chest is going to come back to bite you, so you need to keep that in your mind. But there's no intervention right now, so move forward.
Right.
yeah. I was thinking the same thing. I'm like, I'm not even fucking with that fracture. Fuck it.
Yeah,
I
and
got
like
bigger
that
things
open tip fib,
to deal
right?
with right now.
Like, yes,
Yeah, don't
the
care.
fact that it's not
Don't
bleeding is
care.
putting me into something bigger, but like, don't get distracted on that.
Right.
Right.
Yeah, I'll deal with it later.
How many new and experienced providers would let that single leg injury distract them
Oh,
from
yeah.
the bigger picture? Right.
Yeah.
That happens all the time, right? They get fixated on just that injury. So I'm gonna go to the paramedic intern. What is Megan thinking?
Everything you guys said.
That's cheating.
That's not thinking.
I've been speaking though, Gerard. Have you not been hearing me?
I know. I've heard.
You guys have been pulling a Phil, just.
Yeah, she's definitely not pulling a Phil.
I don't know what that means. So, okay.
That would be not talking to
Well,
the
you
entire
see-
episode.
Oh, I was gonna say there's a hole and it's in the wall.
Nope. Let's not go there. Let's not go
And
there.
Things get pulled.
Nope. No. All right. So okay, Megan, I wanna ask this of you then. What would you like done by these BLS providers within the next few minutes? Other than just pick up, get to your ambulance, call the helicopter, move on.
Well, they need to rule out whether or not there's any visible bleeding anywhere else. They also need to secure that person's airway. Did they do that way back in the beginning?
Nope. They said, hey, he's responsive. They left it alone. So
Okay.
there's no visible head trauma that they are aware of. So I mean, technically they could have put in a NPA here. You know,
that's my favorite. So
I mean, it should be
Well-
everybody's favorite.
I put
I
those.
wonder who
We
you learned
listened to
that
lung
from.
sounds.
I put that
We
shit
found-
in everything. So
It's like Frank's hot sauce. Yeah.
yeah, exactly.
Well, my other thing was they listened to lung sounds. They found diminished and
Diminished
thought
on
of,
the left,
let's
so-
get some O2 going. Yeah, no O2.
Nope, there was no oxygen, no ventilation, no nothing of let's
Okay.
look, listen, and feel, and then oxygenate. There was nothing of
Okay.
fixing ventilations. There was no. It was just equal chest rise. That was it. They
Oh,
moved
okay.
right along.
Cool.
Didn't actually. So it seems like they've found certain things, but they didn't do anything about the things that they found in their primary. Let's put it that way.
Very familiar.
Cool.
Okay. So the primary EMT decides this is the perfect opportunity to grab a set of vital signs, while they tell the secondary EMT to bandage and split the leg wound.
No. Bad EMT. Bad.
Are these manual vitals?
These are manual vitals. Yep. So
Okay.
BP via the manual cuff is 106/76. Heart rate comes back 120 strong and regular. Ventilatory rate
Expected.
of 26 regular but slightly labored. And an SpO2
Expected.
of 90 on room air. That's what they got.
Unfortunately, expected.
So
How about some oxygen?
do we think that any of this is concerning? Like of those vital signs, like other than the 90%, does anything else scream concern to you guys?
Oh, the
In
vital
this
signs.
situation.
Yes.
Yeah.
Obviously, he's tacky, so he's definitely
Heart
trying to
rate, he's
compensate.
breathing.
I would tend to agree, right? You guys both said heart rate's high, ventilatory rate is high. He's compensating for something, right? We already know that there's blood on the ground, so we can only assume that it's fluid loss. And
And he's changing from burnt sienna to lighter shade of wolf gray or whatever the fuck it's called. Yeah, gotcha.
Absolutely.
So I imagine his blood pressure is probably actually, if you take another one in 5 minutes, is trending downward.
I am aware of what happens to it. One would think, but with the presentation, right, with you would think that a normal, healthy 18, 19-year-old gentleman who gets into this accident, who's now unresponsive, would be a little bit bigger or greater than 106 systolic.
Is this foreshadowing?
No, it's actually not.
Oh,
I mean, the pressure.
oh.
We do a lot of foreshadowing on this show, but right now I think we're gonna live in that
Okay.
range.
I mean, you don't know what kind of you don't know what kind of lifestyle he was, but I mean, like, if he was athletic, stuff like that, the 106 may not be a terrible thing. I mean,
That's also true.
Given that he's now tacky and he's, Stickhypnic, I'm thinking 106 is probably a bad place for him right now.
And the loss of burnt sienna color, yes.
That's right. Yes. And the becoming more clammy.
Yes.
Yeah.
So this is the time when the fly car paramedic arrives on scene. Primary EMT gives a report and the medic begins their own assessment. They go and they start at FBOO. They go all the way back up to responsiveness, and they find that the guy is now responsive to verbal commands, is confused, but has absolutely zero recollection of the incident.
Probably a good thing.
The kid tells the medic that he's feeling pain in his belly and his chest. Lung sounds remain the same, diminished on the left, clear on the right. Abdomen, which we didn't look at prior to, is distended and painful to palpation. Pelvis is stable. However, there's some swelling developing on the left flank as well as the left hip. It appears as, instead of like the bubble hematoma, it appears as like a long, long hematoma, almost like if they took like a sausage link that was like 1.5 feet long and stuck it on the side of the flank and hip. So
man, should have called that helicopter, boys.
They still haven't done that. There's no cloud over Omaha. There's no nothing.
We are getting to the point. We're getting to that point where that isn't even going to matter anymore.
You're going to be working this guy up for a traumatic arrest. Yep. Yeah.
Stop talking in a minute.
It's coming.
So the medic is concerned.
That's one of those ones where you find out that they haven't called the bird yet, and you're just like, and you look at them and you go, all right, well, before it all starts, I'm just going to go get something to drink and refresh. Okay. Get ready.
Start stretching.
That's right. You gotta be limber for all those compressions. Start
thinking Uptown Funk in your head. Get that rhythm.
Make sure that Lucas battery is charged, because
Oh, we hold on. We can't use that no more. Just no. I'm kidding.
I was gonna say, I will bitch slap the first person that says that.
Right? Oh my god.
Well, that the studies found that. Bitch, shut the fuck up. Sorry. Go ahead. The
amount of people online that are losing their collective minds over that. I'm like, guys, it just says that it doesn't matter. Pick whatever you want.
It's because we know how the mind of the administrator works. Oh, it says it's not effective. That means we don't have to fucking pay for it. Oh, great. Pull them off the trucks, boys.
I like this new voice of yours. This nasally administration voice. I like it.
That's my pencil neck geek administrator voice.
Better get that tie out,
Yeah, I got my tie clip already.
That's foreshadowing.
Yeah, absolutely.
Yeah, how about that? Or was it a callback?
A callback, yes.
So the medic is absolutely concerned with these findings and decides that this guy has to be rolled because they believe that the bleeding is coming from somewhere else, right? That's not visible.
Oh, okay.
So they end up rolling this individual with help of that lovely nurse who just got forgotten about and was still holding C-spine.
Oh, I didn't forget.
I was going to ask about her.
You left her there on purpose.
Yeah.
Right.
Keep her in class. Keep her out of the way.
Keep her out of the way. Absolutely. And then you make sure you give her a t-shirt
one job
when we're done. All right.
Listen, she's doing a good job.
She's a hero. Are you kidding me? hero. If there's a plaque
All
for
I
this
know is
woman,
that she
she's
actually works
getting
in a
it.
nursing home, so she's never seen a motorcycle accident before. And she's just doing her best.
Right.
That's absolutely true.
I understand. And when he voids his bowels, I'll be sure to call her.
She's helping you right
That's going to happen pretty soon too.
Yeah, agreed.
Right.
So
Nurse, stay right here. We're gonna need you in a second.
Oh. this guy's rolled.
Front to back. Front to back.
They roll him and they find a very small, like half inch wide puncture wound to his lower lumbar near the left side. However, this half inch puncture wound absolutely is spurting like crazy.
Interesting.
So they take a dressing, like a bulky dressing, they slap it on the wound, and they roll him back over. And
we're just gonna forget about that.
They place them on the back.
Not gonna stuff some clotty stuff in there.
Nope. They
No.
just
It's okay.
right on the back.
That's when it's like, whoa, wait, all right, we didn't see that, right?
No, we didn't see it. No, we didn't see it.
Whoa.
That's kind of yes. Like you ever walk into a room and you're like, ah shit, I didn't see that, and close the door. It's kind of what they did.
Yes, I have.
Yep.
It's exactly what I did. Whoa.
I know
Nice
where our
shit.
brains just went.
Yeah.
So Megan, you'll get there. Don't
Yep.
worry.
That's okay. I don't have to.
Oh no, you will.
Yeah, actually, you do.
So
Welcome to the club.
what is
Yeah.
what
Mhm.
is your choice of bleeding control for this type of wound? And do you
Which level of care?
both?
We talking nurse? We
Let's
talking
go.
EMT?
Let's go BLS first.
We talking the PA that's gonna show up in a while? No, I mean,
Nah, there ain't no PA. They don't do anything.
Quick clot and pressure.
Right.
Would you pack the
Is re-
quick
is
clot,
re-
or would
is
you
re-
just?
oh yeah,
Oh, yeah.
I pack it.
yeah, pack it, yeah.
Pack that shit.
I like it.
Wiggle it around a little bit,
I don't know if that would help.
Well, his would probably be a little bit better. It wouldn't go in as far, but
You never know. So let's say that
Just a tip.
just
let's say that the BLS provider goes and takes care of this bleeding, right?
okay.
What do you guys want the paramedic to do at this point in time? What's their
Do they have the TXA?
They do have TXA to be able to
Good.
give.
2 lines, one for volume replacement, one for TXA, and anything else.
Okay. Do that on scene or get them moving
Right now.
right now.
Now.
Yep. And
RFN.
we'll have a conversation about TXA here in a little bit, what it is and why it's used in this particular case. So this guy instead decides, or this crew, I should say, as a whole decides, okay, while that dressing's on, they're going to roll onto the backboard to be able to extricate to the truck. Once they get them inside of the ambulance, they now only finally request the actual chopper. All right. So they
Now,
finally
quick
request
question.
the chopper. Yes, sir.
Is this going to the dressing is that going to evolve into a wet bandage?
I would say that yes, it will evolve into a wet bandage. But one of the things that I do want to talk about with this particular bandage is the crew noticed later on, and I'll get to it, while they were en route to the LZ, that the backboard was not wet. Like their explanation to me was that the pressure that the patient put on themselves onto the board stopped external bleeding.
I was gonna ask if that's what they were thinking.
And
That's called internal bleeding.
Exactly.
And that's exactly what we'll talk about. Yes.
You need volume placement, give some TXA, and then you need bright lights and cold steel. So we just fiddle fucked around for 40 minutes on scene, and we still are 90 minutes away from where I actually need to be.
Yes.
Yeah.
Agreed. 100% agreed.
I love how she just comes in and she's like, this is exactly where we're at right now.
I'm gonna tell you,
Y'all
right
suck.
at the part of vitals with a shock index over 1 and a mechanism, blood, bright lights, cold steel. Let's go.
Yeah.
Right.
100%.
Get in the ambulance. I mean, pack the back while you're on the ground because you can actually reach it. But I agree with them. Like, pack that and let him self-splint it against the board.
Mm-hmm.
You can't.
Yeah.
What else are you gonna do? You can't do that.
But
you
at that point,
all the way up there. Come on.
well, and that's it. The fact that they put an external dressing and not an internal dressing, that's where they screwed up on the bleeding, right?
But even
I don't mind
bleeding regardless. I mean, you can't. You're never gonna be able to stop that.
No.
Yeah, you got to fix that artery that's bleeding in there. You got to,
Yeah.
Well, right. You know, like you can aid it with, you know, the TXA and the quick clot and stuff like that. But again, you need surgical intervention here, right?
But the fact you already have visible physical signs that they are filling with their own blood and that there's not enough going out to the extremity to continue bleeding from the open fracture.
I mean, we
That's
already
telling me,
did
yeah,
that with the distended belly, so we already know.
Yeah, you're
bleeding somewhere.
right. You have all these physical
I don't
signs.
really care where it's coming from.
Right.
That's me to figure out, but like I can't stop it. That's an uncontrolled bleed. I can't do anything about that.
Right. That's we need to start moving.
Agreed.
Move.
So
Yeah.
they call the flight team finally, and they request them to a nearby field. The flight team does accept with a 20-minute ETA. The field is about 7 minutes away. Boy,
if they only would have called first.
If only they used the additional resources tab on their you know, little fancy computers. So yeah,
and now you know
early. Really, the flight team probably could have accepted and been on the ground.
They would have been there
before they
would have went.
It
Sound like they would have made it to the scene.
How long have we been on scene?
Too long.
Probably close. Like the initial crew at this point, probably 20-25 minutes.
Shit. Yeah.
Yeah.
You know,
they probably could have even went right to the scene. Yeah.
Yeah. Depends. So once inside the truck, the EMT goes and they bandaged the right leg, but never actually finished splinting it. So the secondary EMT decides, oh, okay, I'm going to, you know, split that leg because that's
Whatever.
really important, right? And the medic goes and places him on the cardiac monitor. Initial rhythm on the 4 lead.
We have fluids and everything running right now, right?
Right.
No IV has been started yet.
And you put them on the fucking cardiac monitor first?
Yep. That's why I said you guys will love this call. You guys will love it. Absolutely love it. So
you want to watch him die? I see.
I mean,
I get it.
They have
Cool.
to be able to see when the
look
line
at it's slowing down now. Yeah, look at that.
So
that's a funny squiggle,
right?
It's so wide.
Watch. Everybody, watch it. It's gonna go flat. Watch.
Oh man. So 4 lead shows sinus tach rate of 116, and they decide to waste even more time, and they do a 12 lead because you know they got all this time.
What?
Yep. They decide, you know, that chest pain, they got to make sure to rule out, like, you know, who knows, cardiac tamponade or something.
The massive MI that he's not having.
The massive MI that he's not having. Exactly.
I'm going to let Emily, since she's the nurse, ask for the next thing that they did.
I want a blood sugar. No, I'm kidding. Did they look?
That's what I was hoping for.
You said about candy, I was going to bring it up, but not the time.
I knew I could count on you.
I will say, like cat out of the bag, they never take a blood sugar.
Oh,
Oh, that's it. They suck.
I know, they suck,
There's
right?
the QA/QI process.
That's right.
That's it.
gotta give them something to
Stupid
QI.
idiot.
It can't be perfect.
Determine the
That's a
Oh.
vital
HTTPs.
sign. You should know this.
They get
So
a temperature, hopefully. I mean, I don't.
yeah, definitely,
97.7
definitely. Oh, dude, do I have a story to tell you about that?
on your FM dial.
Uh, So of course the 12 lead comes back with sinus tack, no ST elevation or depression, because you know who the fuck
Stop.
cares. Splint is secured, and they finally put oxygen on this guy. Sat is still running
They
low
do-
to mid 90s, so they decide 4
So-
liters is appropriate. They do
So on a serious
nasal
note,
4. Yes, sir.
do they ever like understand? I'm not trying to be a dick about it, but do they ever like understand that the problem is that the patient is bleeding out,
Exsanguinating.
and there needs to be some sort of volume to keep things alive?
Yes. Yes.
That's why they call the
They
helicopter.
do figure that out.
It's coming. You
Codes.
just gotta get
It's 20 minutes away. Okay.
You just got to get
I got you.
through the, everyday minutia of all of this. They'll get there. Give them time. It's fine.
Did you ever re-listen to lung sounds?
Honestly, I don't remember.
Let me guess. We put a couple of 20s and they got maybe a 22 because we're not.
Oh,
In the thumb.
22 in the hand. Yeah.
22 in the thumb or in the foot.
Yeah.
All right. So
Yeah.
The broken one.
honestly, I do not know if they have anything to that effect with the lung sounds. I will add I'll get there and we'll see. I don't honestly remember. So they put him on the nasal cannula at 4. They repeat vitals. BP's 100 over 89 via the auto cuff. 118 still strong and regular apparently. 24 in regular doesn't change. 95% on the 4 liters. So the medic goes and starts the line. Surprisingly, they start a 16 on this kid.
Wow.
not
so
a
they
22.
understood what the problem was.
Yep.
So they did understand the issue. They
I
just
told
chose
you,
to delay.
It's just the minutia of things, right? They hang a liter bag of saline.
Yeah, it's lack of
Infused-
training.
Infused wide open. The kid that I can't say kid, the EMT that is splinting the right leg also finds a femur fracture on the left leg. And they note that there is some significant swelling now to that left hip area.
Is this the same leg? Is this the same leg with the tib fib or different leg?
It is the different leg. So femur
Good.
on the left,
Traction
tib
that shit.
fib on the right. Femur fracture on the left, tib fib on the right. Call it a day.
So now we
notice-
have 2 gigantic areas that could be bleeding inside, that are bleeding inside.
right. I mean, you
The
look
abdomen's filling up, the thighs filling up,
and
Puncture on the flank. So like you could do
and the
retroperitoneal.
flank.
absolutely.
Right.
So like literally this guy's volume could be gone before we do anything.
Where
Right?
did you see it?
Exactly.
Right.
Right? Like we only carry 6 liters of blood and the abdomen alone can hold more than that. So
Yeah, the little blood that they saw on the ground was all that came out of that leg, the fracture, before the body shunted it.
bingo.
So they go, oh, that's not bleeding. Well, yeah, no, yes, he is.
Right.
yes, he
There
is.
is a significant amount of bleeding here, that people are seeing but not registering, I think.
He's about to drop off a
Right.
cliff.
So he's still talking with the providers. He's asking a ton of repetitive questions, but he gives some appropriate answers, but he's still, fairly confused. And now they're off to the races. See you later. Goodbye to the LZ. At this point in time, the paramedic, now that they've hung fluids, they do give TXA. They infuse 1 gram, and for the hemorrhaging. And again, we'll talk about that.
What's left of it?
Bingo, right?
Mhm.
And we'll, especially here in New York State, we'll talk about the use of TXA. I'm not entirely familiar with like national standards. I know that the dosage is different. I don't know if the usage is different. Like the indications are slightly different here in New York, and we'll talk about that.
How much TXA did they give?
1 gram. 1 gram. Again, with the new update, that's different now in New York. But
Okay.
I never said that this happened in New York. So
I'm not saying, I'm just looking at my protocol.
I know. So this kid seems to be broken everywhere, right? We know that the kid's exsanguinating. Other than, TXA and fluid replenishment and hell, blood products, if we had them, and we'll talk about that here in a second. What, if anything, do you guys want to do before they hand this kid over to flight providers?
If I knew more about
I was
his-
just thinking.
Go ahead.
No, I was just thinking about it. I was like, this is somebody I probably would pre-mix and have it ready to go, just a bag of Levo, just in case.
Okay.
There's not really gonna be much to squeeze, but just
But
in
I
case, it might buy me a
the-
few extra minutes.
I like the
Yeah.
planning of it.
Yeah.
I do like that.
Honestly, I've pre-mixed more Levo than I've ever probably used.
Mm-hmm.
I've had bags ready to go, but just, thank God I never had to use them because what I was doing was working. But yeah, it's just something that's like a force of habit of mine. Like if I get something like this, like usually, nasty trauma or something where I know it's a lot of bleeding. I know I'm going to be starting lines. I'm going to be getting fluid going and all that stuff. But yeah, I'll usually just, because what happens when people bleed? We lose pressure. So have it ready to go so you don't have to sit there and fuck with it and do all that shit. Yes, it's a Halligan in my hand. Sorry.
That's just weird. Just weird.
I know.
Not cool.
It's just I was thinking back of those fire days, and I had to start playing with my Halligan. I like to look at it and stroke it a little bit. And, I'll put it down. I'm sorry. I started having this hero thing in my head, and I was like, I just got to grab a Halligan.
Clearly, weirdo. What are you thinking, Megan?
I was thinking along what Emily was asking earlier. If I knew more about their lung sounds, I'd consider decompressing the left side if they were getting attention.
Yep. And yeah, so they do end up checking lung sounds later on. I'm looking at that sentence here. Still diminished, present on the left side, clear on right. So nothing really changes.
Other thoughts on decompression?
It used to be a thing.
You guys?
When you were in a trauma.
What'd you say?
I was asking you guys about your thoughts on decompression.
We used to have a thing when there was a trauma. You used to decompress.
We used to have
Right.
pants too, but look at us now.
Fair.
I mean, this
I
guy
know
would
that-
actually benefit from mass pants at this point, as long as we dicked around on.
I don't know
because
if
I was thinking about it. Well, yeah, because I was thinking about it, and I was like, I don't know if I was there yet with the decompression, but that might not be a bad idea. That's why I was wondering if you guys had any thoughts on it too.
Well, I was thinking too, like his pulse pressure is narrowing and his heart rate is still tachycardic. He's still hypoxic, but it's not getting any worse. And quite frankly, like
Right.
his left lower is diminished, and like we know he has a belly full, so it's going up.
Yep.
I don't know
Right.
if I would have thought to decompress. I don't think you're wrong. I don't think it wouldn't have done any more damage. I'm not sure if that would have been my first thought.
And
I do think that I would have put a pelvic binder on him just for mechanism and because get it done and over with. It doesn't really hurt.
that's an
Right.
interesting move. I
But
like that
put a
thought
pelvic
process.
binder on everyone.
Yeah.
Give me an option.
And one of the things that like I know you and I, Gerard, have disagreed in the past about when to use and when not to decompress and stuff. So I'm gonna throw my thought process in here in that we're kind of like looking at it from a strict protocol standpoint. We are kind of pigeonholed into we're only allowed to use it in certain times, right? And unless we are looking at tension type
Right.
symptoms, other than a traumatic arrest, we don't really have the ability to just dart them because we're getting there. And
Right.
and as much as I would tend to say like, hey, okay, I know what's going on with him because I wrote the story, I interviewed the crew. I know what's coming. Would it be helpful? Sure, possibly, right? But his sats aren't falling. He's still labored breathing. Do we know if he's got any type of chest trauma, hemo, pneumo, whatever? He's bleeding everywhere else. Why can't he be bleeding in the lungs too? He stated his chest hurt. So clearly he did something to the chest. But that's
Find out if there's blood in his chest when we decompress him.
then that's true.
I mean, you can find that out if you had ultrasound. Throw the ultrasound on the chest real quick. Like that's what I would have done.
I mean,
But
that's cool.
the call volume's down, and we can't afford that.
Yeah.
If
I
we
don't
got the
think anybody
ultrasound, we
would
couldn't
wanna-
have our
I-
pizza party.
Yeah, right. I
Right.
don't think anybody
Right.
would get trained on that.
I just want you to know
Yeah,
that if I ever pull up to an accident, my first words is, "I'm a nurse."
Ah,
I'm doing it.
growl.
Old head stabilization with the best of them.
There you go.
Right.
You should do it in your flight suit. Be like, I'm a nurse. And then just stand there in your flight suit.
Then I'd be like, oh, okay, cool. Here, you take over. It's all you.
I love that. I love how just the outside shell changes and now it's like, oh, we respect you. Yay.
Right. I respect you now.
Oh, you
Right.
are a higher level of care.
Right. So you don't just wipe ass all day. Okay, cool.
Oh boy, some things never change. I love it. So I really like the thought of the pelvic binder, and ultimately they end up doing a pelvic binder. But the flight team decides to do a pelvic binder, not the ground team. It was the flight team that ends up doing the pelvic binder. So,
of course.
But they also,
we can't afford pelvic binders. We just have sheets,
right. But they
Right.
also
Call volumes down.
They also don't use the pelvic binder for the pelvis either. We'll get to that. So they think a little outside the box as well.
They put it on his head.
They need a crown, man.
Right. Yeah.
They need a crown. So all right. Let me hold that conversation for afterwards. All right. So the ambulance arrives at the LZ. Flight team gets in, and they give the whole rigmarole to the flight team. The flight team does another full body exam while the ground paramedic at this point, is getting another set of vital signs. I'll give you those here in a second. The flight team confirms the femur fracture. They also note that there's a fair amount of swelling to the quad itself. They do a traction splint on that leg. There's the frac pack on the lower right leg, in place from earlier. They decide to remove the dressing on the back and pack it at this point with the quick clot
Shocker.
and gauze. And then they throw a pelvic binder on, not the pelvis, but the abdomen to hold that in place. Which I thought was an interesting
Yeah,
use
I like
of
it.
that.
Kind of like a junctional tourniquet,
w-
just to crank it down.
Yes.
Yeah.
Right. Almost
Nice.
like the Israeli bandage, but just bigger.
Yes.
Just bigger.
So I would give $1 million pesos to have been in there and seen the look on anyone coming off that helicopter's face when that dude handed them the fucking 12 lead and said, "Oh, here's the 12 lead."
Gerard, it happens all the time.
Hey, it's regular.
Oh, I have no doubt.
It's regular. If they're not having an MI, sir, it's fine.
Great. Thank you so much for your help. Thanks for calling us.
Yep.
The only time they get a 12 lead is like if I'm waiting for the chopper to land and I got like 5 minutes, I'm like, okay, I'll do my 12 lead now. Like I just got
Here's
this
the
when you
thing, though.
landed.
The
But
flight crew doesn't care. Your
Yeah, no.
question earlier was like, what do you want to do before the flight crew? The flight crew doesn't care what you did. Just tell us what you did and we're going to keep going. Like,
Right.
we're just
That's
happy
it.
to be here, okay?
Yep.
got to play the
Happy to be
helicopter.
So let's see. BP's 102/91, heart rate 114.
Holding.
Respiratory rate increases slightly to 26, and
It was 26 before. Fuck it.
right,
It was.
and 96% on the 4 liters still.
Oh, good. So everything's holding exactly where it was, and the O2 came up. I'm good.
I mean, we fixed them. Duh.
Right? Done.
We
He's
absolutely
done.
fixed them.
Sign
Done.
here,
Get the
RMA,
RMA.
send him home.
Done.
He's
Get
fine.
that RMA, baby. Here you go.
It's good. Send him home.
Yep. So,
Get a hold of your primary doc. Make an appointment. You're good.
That's
yep.
it. Hey, there's no bleed, no gross hemorrhage, and
Oh, no, it all
everything's
stopped.
everything's okay. And
I
the 12
mean-
lead was fine. That's BLS. There you go.
Emily's sitting there like, I'd take that BLS 100%.
Right.
I can't take me on
So what do you guys think overall? How'd this call go?
Could have gone better.
Could've
Could
gone
have
better.
recognized a few things earlier, or at least started a treatment processes earlier.
I would say the prioritization was fucked.
Yeah.
They needed to prioritize things in a more priority way.
Oh,
Fancy.
fancy.
Yes.
I think you just
Yes.
Kamala'd the shit out of that sentence.
I did. See, I was unburdened from what has been. They were unburdened from what has been. Yeah. Yeah. It was as soon as they gave him to the flight crew.
Absolutely.
No, their prioritization needed some work because they may have recognized what was going on, but their thought process of, that part of memory that goes into action and translates to what you're doing with your hands without thinking about it, that you only make that good with training. If you don't train, you end up doing 12 leads on people that are bleeding out in front of you.
Mhm.
Because you're going, well, it's a ALS call, so I got to get my blood sugar and do my fucking 12 lead and all that. And you're like, yo, dude, wrong fucking patient. You know what I mean? That's great if you got grandma at the nursing home. Fine, do that. But this ain't grandma at the nursing home.
Right.
Or if you have time after you've done all of the others, all of
right.
the other priority
Absolutely.
stuff.
If I'm sitting around, I got nothing else to do. Sure, why not play with the equipment? There you go. Push the button,
Well-
make it do noisy things.
Do the things, the ALS-y things is the
Right.
motto. It's
The things. Make it do the first
Right.
thing.
Hey, let's thanks.
Make it do things.
Megan, as the paramedic intern of the crew here, how would you assess this overall, the call as a whole?
Well, can I go back to being an EMT first?
I mean, sure, if that's where you want to.
Way back in the beginning, how's the driver of the car?
We don't know.
Who cares?
Nobody ever looked.
He's laid across the hood, dead. Just don't worry about him.
Notice
Don't worry
how,
about that guy.
notice,
How many
notice,
patients do I actually have on this scene?
notice
Don't,
how
don't, wor-
I
don't worry about
never-
that guy.
Notice how I never even gave you the damage to the other vehicle.
No.
Yeah.
No, nobody ever knew.
but they have to be there.
Clearly.
Do they?
But
I've watched enough cops to know that they don't have to be there.
and I think you bring up a really good point in that, like, they got tunnel visioned into this one patient that, yeah, like Maha said, that driver could have been laid out over the steering wheel and they would have been like,
Right.
we have another
Oh, you're still
patient?
here?
What?
Yeah, that
still- he's
driver's
still-
really calm.
He's still in the tow truck going to the Crusters right now. Don't worry about him.
Right.
He heard too much. You saw nothing.
Right. Right. Okay, in a couple days, he'll be part of a Lincoln, you know? Nobody will know.
I mean, as a paramedic intern, I was looking at my protocols for TXA. I don't know where this was. I know that we in New York could give more than what he gave.
Mhm.
We could have given 2 to start.
Yep.
Um,
the
I'm all for calling for helicopters like way early, because
Mhm.
I have heard calls. I've been en route as a backup crew where they have called for a helicopter. Somebody else has canceled the helicopter before they ever get to the scene. And then when they get to the scene,
I
they
hate
need
that.
the helicopter. And so they call the helicopter back. But now that helicopter's been assigned to another call. So now the wait time for that helicopter is like double. So
Yep.
I'm all about
That's why I always say.
putting a helicopter in the air and, you know, apologizing afterwards when we
That's
release.
right. Claim that shit. Because once you claim it, it's yours.
Right.
Nobody else can touch it.
Apologize,
It's
like,
mine.
truly, even if you land them and then you're like, hey, like, this is what I got, but I don't really need you. There's no harm, no foul. Like, there's nothing that says that because we land, we have to take it. We're just, we're just happy to fly. We just want to be in the air.
And
It's
they're an
fine.
extra set of eyes to look at something that
Yeah.
you may have missed and
Sure.
been like, oh, wait, what about,
Here's
you
2
know?
more brain cells that
Mhm.
you can be like, hey, this is what I got. This is what I think. What do you guys think? And they'll be like, yeah, that's a great idea.
Yeah.
Let's go. You want us to come with you on the ground? We can do that too. Whatever.
And I've had it where they've gotten there and the patient arrested. We're all working the arrest together. We say, let's go to the hospital. We're heading for the hospital. We're all working the arrest. Patient comes back. Hey, move the helicopter from the LZ to the fucking hospital. We'll meet you there.
Yeah, we can do that.
You know,
There's no
and we're all in the back of an ambulance together having fun.
exactly.
Circular, working it.
working it.
Working it.
No, I 100% agree.
Circular.
And remember, like, you and I always talk about, Gerard, in our MCI lectures, like, I would rather call every single aircraft to me and then be like, hey, sorry, I didn't need you, than, you know, get stuck with nothing. Absolutely
Yeah.
nothing. And yeah, it really, it grinds my gears too when people, you know, don't even look at their patient before they ex-nay the helicopter. It's like, are you flipping kidding me? Like, don't get rid of a resource that not only can transport faster, but carries blood products, carries different meds that I don't, right? And again, can get them there faster.
Yeah.
You know, think about it. Like, it's a 90-minute drive. It's like a 33-minute flight. Even with the delay on scene, you're still getting them there faster. Like,
if you look at it as a commodity, right? And you know that flight crews and helicopters are a limited commodity.
mhm.
So you hear you getting toned out for something that sounds juicy, right? Car versus motorcycle. Hey, I don't need a fucking slide rule to figure out, you know what? I'm going to go ahead and get me my little helicopter before anybody else steals it from me.
Yeah.
And then if I don't need it, I can give it back, put it back in the toy box. But yeah, if you look at it like that, then revert to your fucking inner child if you have to, and just be a selfish little bitch. You know what I mean? And just be like, yeah, that's mine.
Mhm.
You know, and that's why you got to think about it. Because yeah, like you said, if you don't, someone else will get it, or that IFT is going to get called out to Boston Children's or some shit, and off they go making that
And then
money.
you're sunk. You're sunk.
Yep.
Especially when it happens. I couldn't tell you how many times it's, you know, Jess has come home and been like, oh yeah, you know, we got called to a scene call. We were halfway there. They canceled us. We turned around, then got an immediate inter facility. And then 10 minutes later, they called us back to the scene and we had to deny it. And then the helicopter from 45 minutes away has to go and respond. And we're 3 miles away from the scene.
Or you
Yep.
bring them to the closer hospital, and instead of it being a scene call, now it's an interfacility. We'd rather
Yes.
scene call.
Yes. Yep. Which
Yeah.
is even worse because then it's like, okay, then the doctor, you
Yes.
know, that wants to be a hero plays hero for 4 hours and is like, why didn't you send this 4 hours ago?
Yeah.
So we got a couple things to talk about. I want to talk about blood loss. I want to talk about TXA, but I also want to talk about blood products. Because you know, New York State is really pushing hard for and again, I don't know. I haven't really looked into what the rest of the country is doing with EMS and blood products. I know it took a really long time for the aircraft here in the state to be able to get blood products.
I remember they had it and then they lost it and then they got it back.
Right. And that took
Yeah.
like a decade. It was incredibly retardedly long. And now they're looking to, you know, start allowing paramedic level agencies to have blood products on the ground with special training. And, you know, I don't know what New York is going to do. I haven't looked at it. Those are in, you know, the higher up meetings. But, you know, probably within the next 2 years, hopefully, they're looking at least trialing ground blood products here in New York State, which I think is really cool. But, you know, we run into this problem where we need fluid replenishment, but all we're giving is salt water, and that's not housing any type of ability for them to coagulate or transport oxygen or transport carbon dioxide. It's literally just let's take some water, pour it in a container to fill the container. It doesn't actually do anything for the container. So allowing, you know, the packed red blood cells and the plasma and stuff like that, you'll be able to actually help replenish the volume that's lost in your patient. The biggest mortality risk is the loss of volume. And what do? We turn it into Kool-Aid, right? That's what we always say. We turn it into Kool-Aid and then they crash because they don't have perfusing volume. By giving...
Well, I mean, there's also...
Go ahead.
Yeah, go ahead.
No, go ahead.
I was gonna say, I mean, there's also something to be said about, you know, not putting ringers on the truck. And then also, I mean, I know that, you know, the blood product, I mean, you got a whole chain of custody thing and accountability and then the money aspect and all that stuff. And I do know, and I forget what it's called. Maybe y'all can remember it. I don't. But it's used in Australia, and it is a solution that has oxygen transporting capability. Like it mimics, it's some kind of like synthetic shit, and it mimics the red blood cell. I forget what the fuck it's called now. If anybody out there can remember it, fucking comment that shit because I can't remember it. But yeah, I mean, like there's options like that should be explored. You know, I mean, blood sounds great. I like this. I would love it if every truck had the blood on it. But I mean, realistically, I mean,
I don't
nickel
think,
and dime over fucking IVs supplies.
I don't think that it's going to end up being across the board. I think they're going to say it is, and then people who want involved in it are going to be involved in it. You know, I know the agency that I work for, they're already planning for it. You know, they've bought the equipment. They've bought this piece of equipment. They're just waiting. And
are they going to do like PRBCs, plasma, that, or are they going to do whole blood?
Couldn't tell you.
I always advocate, like, I do think that blood products on the ground are a good idea. I don't think that every single agency needs them. I think, you know, one bag of blood, we carry whole blood. So one bag of whole blood is $500. You get about 15 days and then you throw it away. So I understand the expense behind it. I think, if you're going to get every ambulance to have blood, you're going to have a supply issue. We get our blood from like Texas, which is crazy. So if you start putting that on the ground, it's crazy. Interestingly enough, though, I was listening that in New York State, the state police are looking at it, which is interesting because they're on scene a lot. and they still have paramedics in our state. But I think that this is where I get concerned with doing it on the ground, because I think you have to collaboratively work together and figure out the best spots for it. I don't think every agency needs blood. I think that's a waste.
Right.
Do I think that EMS is going to work together? Who knows? But I think,
Probably not. I mean,
the benefit of giving blood is way.
They haven't so far.
Yeah,
I was going to say that no one's done it so far.
I think the benefit of giving blood is higher than not, right? Like when you do go through QI and you look at all these things and you're like, oh, blood would really help them. Or you give the blood and you're like, I don't really think they needed it. It didn't hurt them at all to get the blood.
Right.
So the benefits just outweigh the risk. So, I mean, I would love to see it on the ground. I know
Well,
it's
and you look at the drop in mortality of all of these patients that get whole blood or blood products in the field, and the survivability is so much more. Granted, I didn't pull up those numbers, but I mean, I've had the conversations and looked at the stuff. They are clearly increased mortality, or increased survivability.
Yeah.
Because of the transporting properties of the blood products. So
it's the combo, right? Because if I'm just going to fill the pipes and I didn't do anything for the bleed, then like I'm defeating the purpose of having blood. So it's a combo. It's a whole blood program. Like just having blood isn't the solution. So, be smart about this when agency implement this and come up with the entire program.
Right. Now, what do you guys think? One of the things that I wanted to talk about with the whole blood products situation, and one of the things that like agencies are going to have to navigate, is the religious aspect of blood products, right? So like Jehovah's Witnesses will not allow blood products to be given under any circumstance. So, as far as I'm aware, I'm looking at what I pulled up now. So like, Christians, no, like, you're permitted to do whatever.
Right.
Islam, Judaism, Hinduism, no prohibition against blood transfusions. The only one that's significant that says absolutely freaking not is Jehovah's Witness. So like,
tough shit.
well, and that's it.
Well.
So like,
do the best you can, right? Like you're not acting in malicious intent. If this patient's unresponsive, nobody has any idea who they are, and I'm giving them blood, I'm doing the best I can, right? Implied consent there.
Yep. Right. Implied consent.
If they're conscious, you do the best you can to find out if they can have blood. It's the same thing with like religious beliefs on like, oh no, or whatever, not even religious, just beliefs on like, I don't want pain meds. It's my job to educate you on the risk and benefits. It's your job to make the decision.
Right.
That's one way to find out how we're.
I'm going to work and I'm going to do the best thing I can for you.
Right. Exactly.
I think it's the same.
I was going to say that. Yeah, that's absolutely correct. And I'll tell you what, that's one way to find out just how strong their faith is. Because if they're conscious and you're like, I need to give you blood. Oh, I can't do that. Oh, if I don't, you're going to die.
That is their religious belief.
I know. I'm just, that's a great test.
You see it a lot.
We'll see
the Amish.
We'll see how faithful you are.
That they will allow, and there's certain things they don't, and it's a tough situation.
Well, and that was
you're talking to the guy who flew an Amish guy.
So and this is why I bring this up, right? Is I agree wholeheartedly if you don't know who they are and they don't have, no blood products tattooed across their forehead, implied consent, you're going to do what you're going to do.
Interesting tattoo.
Right? It would be.
Right.
But for those
cut here.
Yeah. For those that are conscious or can, give consent or have this conversation, right? Having that educated conversation, and not just like, one of the things that I think will not be good about that is so many providers will be like, I don't care about your religious beliefs. You're not going to die and I'm going to do it.
Or they're going to honor the wishes and be like, well, you don't want blood, I'm not doing anything. That doesn't mean you don't.
Or it's one end of the extreme or the other. And I think that's where we're going to fall. And I think that's ultimately what's going to kill us in having these new tools, is because it's always all or nothing. You
Which
know,
is
there's
hard, it's a hard pill to swallow because I get it. Like nobody is here to do, we're not purposely trying to do a bad job. We don't want to suck at our jobs, right? But when you sit there and like you have the closed mindset, like you can't take it personal when they refuse a treatment. It's
right.
not, it's nothing against you. It's nothing, they're not trying to kill you. You're not trying to kill them. Your job is to educate them. I tell people in the hospital this all the time. All I can do is educate. It's their responsibility. Like it's their job. If they want to make a stupid decision, all I have to do is tell them how stupid it is. Like it's still it's their
Hallelujah.
call. It's not my decision. It's theirs. All I can do is educate.
Yeah.
Just make sure they sign that form.
Well, and that was the other thing too, is now they're refusing a treatment, right? Whatever the
Right.
whatever the belief, whatever the reason might be. This is one of those where you're like, okay, hey, I know you're bleeding out, but like right now before you exsanguinate and die, I need you to sign this.
That's right.
Use the pad, not the nail, and sign. Whereas so many other people, like, they don't get RMAs for treatment refusals. Like, oh, hey, don't do this on me. Oh, yeah, whatever. They refused in my chart. Well, where's the refusal form? Right? Did they?
No, I will write. I write on the piece of paper or on the form, and this is what they are refusing. In fact, if it's if it's a refusal of a treatment, that's when you go write the paper, so you can write it the fuck out.
Yep.
And write it right out, and just be like, here you go. This is what it says. This is what you truly want. Cool. We're done.
Right.
You
Yeah.
know?
We have to look at that. So now I'm going to transition over to TXA, right? So TXA, or trans ischemic acid, is it's classified as a antifibrinolytic. So it helps the body not break down clots. It's the long and short of it, right? So ultimately, our body creates a clot when we're bleeding, and then through our clotting cascade, it then will attack the clot and break it down. Well, TXA blocks it from being able to break down said clot. So the hope is that as we give the TXA, we are lengthening the lifespan of the clot and allowing the body to bleed less. There's two specific trials and like one trial, one study that I pulled that shows there's a Crash 2 trial years ago saying TXA within 3 hours of injury in bleeding trauma patients decreases mortality, decreases death due to bleeding, especially if given within the first hour. And there's no increase in clots or thrombolytic events. So like no MI, strokes, DVTs, PEs, stuff like that afterwards. And then there was the Matter study that was specific to the military. And that one more or less showed there was a increased survival benefit in casualties who needed blood products. So those who got blood products and got the TXA showed a larger survival benefit, which I think, shows to what we just talked about. New York State did just increase our dosage from 1 grams to 2. But New York State also says that they need to be hypotensive to be able to do it. So like, even if they have a shock index and you're like, oh man, they're totally in shock, but they're not hypotensive, you can get your pee slapped for that.
So I think New York State is
but they don't have PPs
against the fact that, how do I say this properly? A lot of providers can't recognize hypovolemia.
I mean, and that
Or
could be.
hypovolemia from bleeding. Let me put it that way. Exsanguination.
Right. And that 100% could be the reason. I don't know the reason behind it. I'm not sitting here to debate that. I'm just saying, hey, this is what you know, the guidelines say is typically with, you know, it's going to be a long extrication, or it's going to be a long drive to the ER, or they're bleeding of whatever cause and they're hypotensive. Now we can give the TXA. It's not like, oh, hey, they're rapidly bleeding and, you know, they're still 120 over 80 and I have 20 minutes to the ER. They don't really want us using it for that. You know, they want it for the long transports or the long extrications or whatever, where they're a little bit more hypotensive.
Free drug. Like if they're not going to exsanguinate, you do have a really high risk of causing a clot, which could be a bigger issue than whatever they're bleeding from. So I do think that it's give and take.
Absolutely.
But TXA proved, I mean, TXA has been around since what, the 60s? Because they used it primarily with OB patients. And that's where you see it. Like, who's going to bleed the most? Your OB patients. And you can't stop that. There's no way to stop that bleeding. So, like, TXA became really effective for that. But they saw side effects, so.
Yeah.
You know, give and take.
Give and take. And I think the other thing that I wanted to touch base on here last is be aggressive with our bleeding control, please. Like these guys weren't really all that like aggressive with bleeding. There's a lot of internal bleeding with this patient. You know, there's probably kidney damage, there's femur damage, there's bleeding into the bellies, there's bleeding into pelvises. There's a lot of bleeding going on. And let's be a little bit more aggressive than just a bandage, right? Let's pack the wound. Let's use quick clot. Let's think outside the box and like, hey, you know, utilize that pelvic binder as a large tourniquet, you know, like the flight crew did. I think that was really interesting, you know, something that you don't see or hear that often, especially if people don't have Israeli bandages, you know. We can bleed out fast, and I don't think people really realize like how significant and how quickly we can change from like, hey, this is minimal shock to this is like death shock due to bleeding. All we have to lose is 40%. You know, 40% is like just around 2000 or, you know, 2 liters, 2000 mLs, right? So like, we don't have to lose a lot to be dead, right? When it comes to loss of fluid. And I think, like you said, people don't recognize that in EMS as a whole very well, especially when it's internal.
Yeah.
You could lose 2 liters just inside one thigh.
I mean, you could
before you know, like,
probably not all that distended at 2 liters. So like it's just hard to see it. It's hard to recognize it when you can't see it.
Agreed. You have to look for outside symptoms. You know, you got to look for the blood pressure changes and the mental status changes and the
skin.
All the skin, and you know,
he had all of that in the beginning.
He had all of that in the beginning.
Just from MOI.
Almost clammy.
Yeah. Almost. That's true.
Oh, I'm sorry.
Almost. What was a fuchsia pink? What was it? I don't even remember.
Burnt sienna to
sienna. Gotcha. That's right. Yeah. Not like that helps any, but you know, we'll call it a day.
Well,
anything else?
Well, it does if you had the big Crayola box when you were a kid.
I did not. I had the tiny Crayola.
The only thing I would add to that is I think that when you go on scene with a crew, and it's hard, like this is obviously easier when you have a regular partner, and you know, I still work the ambulance and I get a different partner every day, so it's tricky. But use your resources. Like people do not need to do every single part of the assessment. Divide and conquer, right? Like crew resource management. Take somebody that really wants to do trauma, go top, bottom, whatever. You're going to get a lot more done a lot faster, but then you have to communicate it, right? Like if I'm seeing things in ABC, or if I'm seeing things from the torso up and they're seeing things from the torso down, like communicate that. But so often I see that like an entire ambulance is looking at the same thing and you're missing so many more things because there's 6 sets of eyes on.
That's fair.
And like, yeah, that's cool. That's great. You guys did a great assessment on that, but like divide and conquer.
Agreed.
Especially when you're all BLS waiting on a medic or something. And then when a medic gets there, that doesn't mean that BLS are hands off or good. There's still things to do.
They turn into clipboard holders.
That BLS can. So
not all of us.
Wait a minute. We never found out. What happened to the nurse? Did she ride it in?
Great. Leave her alone, Gerard. She did great.
She's with the driver holding stabilization.
Listen, that took
Who's
one
driving?
and that didn't have to hold stabilization to do something else out. She did great.
Because I'll tell you, they never put a collar on this kid.
Nope, they didn't. They put him on a backboard, never put him on a collar. So kudos to the nurse.
Yep. Kudos to the nurse.
She did pull off that stabilized log roll single-handedly. That was,
I mean,
a feat in and of itself.
Pretty impressive.
Yeah.
I'll call that
Pretty impressive.
traumatic.
She didn't check his
stabilization
back, and
log
if she had, she would have found the puncture wound before she rolled him on.
Well,
You could have done anything with it anyways.
that's true.
You ain't got no
Yeah,
supplies.
she could have. She could have went.
You're it. You can do that.
Yeah, absolutely.
That's right.
That's a terrible.
That's nurse 3 level. This was only a nurse 1 level.
She did great.
She's at
And
the,
she's
AA
not
she's at the
saliva.
AAS level.
Too.
She's not that BSM level. She's just the AAS level.
Right.
Right.
You know, this is why they earn the big bucks.
We all are ASs
right.
alone. Listen, we're not professional anymore. Relax. We can do whatever we want now.
Totally.
Welcome to
There
the
you go.
club.
Well, guys, thank you very much.
First time.
Hopefully Megan enjoyed herself. What do we say, Megan? Enjoy yourself? Yes, no, maybe? Yeah. She's like, I don't ever want to do this again. You people are insane.
The high pitched. Yeah, you could say yeah,
Yeah,
sure.
yeah.
Yeah.
Oh,
It's
yeah.
great. It's like,
But you see the real us on the show. It's terrible.
it's like that.
I will say
yeah.
I've only listened to it. I've never watched it. So
Sure.
yeah.
I'll call you
I think
again. Sure.
I
Yeah.
think it's easier to watch it or easier to listen to it than watch it.
much easier.
No, don't call me. I'll call you. That's okay.
Not
See you later, Gerard.
Yeah, we had fun. It was great. It
Yep,
was great.
absolutely. All right, guys. Thank you very much for listening. Thank you for following us
Yeah.
all these years. It is amazing to still be here with you guys. We are going to be pumping out the brand new episodes here over the next coming weeks. So if you got calls that you guys want us to review, send them on in. medic-materials.com has the link. You can click on it, fill out the Google form. It'll come straight to me, and then I will give you a call and we'll talk about it. And then it'll be on a future episode, and we can sit there and, crack jokes about you in the
Yeah.
nonsensical terms, because I'm the only
I
one.
was just about to say that
So,
there really isn't I was gonna say that's really not an incentive to get people to send stuff in. It's like, hey, by the way, you can send in your calls and we'll review them.
We'll call you an idiot right
I mean,
online.
Yeah, well, right.
The nice part is people still do it though. I mean, people do, and you just go, kudos. You are brave. You are the future of EMS that we want.
Right.
And
Hey, people self-flagellate too.
There's nothing more exciting than submitting a call in here and then have it ripped to shreds, and you're like, well, damn, I thought I did okay.
Oh, shit.
I mean,
Right.
realistically, we've all done that to
All
each
right,
other.
Oh, yeah.
So, I mean,
Oh yeah.
I thought I was a good medic.
I've walked away with
Right.
my tail between my legs many times during this show where I'm like, okay,
Oh,
I'm going to present this awesome call. I did so good. And then Gerard's like, this paramedic's a fucking idiot. And I'm like, boom. Cry on camera. And I'm
It's
like,
just like
if
it's
only
me.
he knew it was me.
Hey, I still remember the one I put in. It was mine, and Em's like, "Why the fuck would this moron mix a fucking 100 bag with Levofed?" And I was like, "But he did all the math."
I thought it was smart.
But I mathed. I did.
I did math and everything.
I couldn't tell you how many times, Gerard, you and I have had the conversation where I'll put in a call, I'll change things all around to make it a better call because it was mundane or whatever. And you're like ripping this paramedic to shreds. And it's like, oh, you're tearing him limb from limb. We get out of the call and you're like, whose was that? Was it somebody we know? And I'm like, yeah, it was mine. And you're like, great job. You did fantastic.
Right.
After just lambasting me for an hour and a half.
Right.
So yes, you could be all part of that. It is the fun aspect of the show. So
Very rewarding. Yes.
it is
Yes,
a very
yes.
rewarding experience. There are many things from this show that I take with me outside of here that I'm like, oh, the Maha said that. I should probably remember
Right?
that. It's one of those things. So again, check out medic-materials.com for everything, or the CME Academy. You can get the link right on the website. Thank you all for joining us. Thank you, Megan, for joining the madness. Hopefully you don't run away with your tail between your legs going,
Ooh, the
this isn't for me.
Not my call.
Madness.
Did she join the madness? Yeah.
Oh,
Uh-huh.
yeah. I just hit it
Yeah.
for you. You're welcome.
It's the mega powers. Yeah.
Oh, we're breaking out the mega powers. With that, thank you all. Stay safe out there. We'll see you next time.
Yeah. All right, that's where we're going to have to leave it for this episode. If you got something out of this, education, validation, or just a comforting reminder that you're not the only one dealing with this nonsense, do us a favor and follow or subscribe so you don't miss what's coming next. And don't stop here. Go queue up another episode. There's a good chance we already said something that will either make you better or make you mad enough to think about it on your next shift. This has been the Medic Materials Podcast. Real EMS conversations, zero corporate polish, and education that actually applies at 3 a.m. You can find CMEs, merch, and everything else we're building over at medic-materials.com. Until next time, stay safe, eat a donut, and please, for the love of God, answer your QA flags.